Thank you for your presentation and for your time. It was wonderful. I think it's truly a game changer, and thank you for your time today. So so the first thing, we had, the question that came up was, what has changed? What are the biggest take-home points from the study itself?
Yeah, so what has changed is an important question. It's more so not much has changed, but we have confirmed the initial findings that we saw in EXPLORER-HCM3. So patients with symptomatic obstructive hypertrophic cardiomyopathy experienced significant reductions in their LVOT gradients. The symptoms improved. And follow-up studies even showed that there were some structural changes to the heart and improvements in left ventricular mass, left atrial size, diastolic function, and so forth. So this was all good. I think the missing puzzle that we needed now was, what if we take this drug for a longer duration of time? Because conceivably, if patients will be put on this drug, they probably will have to take it for years or even decades. So longer-term follow-up, longer-term efficacy and safety was really key for the MAVA-LTE, for the long-term extension study that I presented here at ACC. And the main findings were that very consistently with the parent study, thankfully, LVOT gradients came down dramatically, patients felt better, NT-proBNP levels dropped to significantly to very low levels. And also what was very important, I think, here is to look at the safety, and the safety was also excellent.
Oh, that's amazing. So let's dive deeper into the efficacy aspect of it. So how did symptoms change in these patients, and how was it measured?
Yeah, so pretty rudimentary. I mean, NT-proBNP by itself, I think, is a very good marker of symptom status. So the vast improvement of that suggests that patients, they really should feel better. And then we just simply ask them, how do you feel? What New York Heart Association class are you in right now? And we found that 68% of patients had at least a one-class improvement of the symptoms at week 48. So and there was only in the single digits patients who progressed their heart failure symptoms. So most patients actually, felt better.
Wonderful, wonderful. And what about the echocardiographic markers and anatomical markers that we use, like EF and LVOT gradient? How did they change?
Yeah, so we assessed LVOT gradient at the sites, at the study sites. The previous studies, the EXPLORER-HCM, the VALOR-HCM that we heard of just yesterday here at ACC, all used central core labs to evaluate left ventricular ejection fraction and gradient measurements. Now, in this study, we based titration of the medication by site-read echocardiography. So this will happen in clinical practice. We're not going to send the echo to the East Coast somewhere and somebody will read it for me. We have to decide what to do with this medication. So we assessed left ventricular ejection fraction, and as expected, because that's part of the mechanism how Mavacamten works, it did drop by about 7% at 48 and by about 9% at 84 weeks. But then this reduction was really stable throughout the follow-up. On the other side, we evaluated LVOT gradients, both at rest and after or during Valsalva maneuver. And the drop in gradient was really quite significant. It was over 35 millimeters and sustained for resting gradient, and over 45 millimeters following Valsalva provocation. And overall, if you want to make this a little bit more clinically meaningful, at 84 weeks, 83% of patients achieved the goal of having a Valsalva-provoked LVT gradient of less than 30 millimeters, suggesting that now we took obstructive HCM and turned it in 83% into non-obstructive HCM.
So help me understand how do septal reduction procedures fit into the larger scheme of things, given these results?
Yeah, so that's very important, I think. So septal reduction therapies like myectomy, surgical myectomy, or alcohol septal ablation is unfortunately still necessary in a lot of these patients because beta blockers, calcium channel blockers, and disopyramide oftentimes do not sufficiently reduce gradients and make patients feel, back to normal or more livable. Now, with this new medication, there's, I think, the big hope that use of Mavacamten can actually delay or maybe even long-term prevent any need for invasive surgeries. And we just got new data on that specific question in VALOR-HCM. Admittedly, the outcome was measured at 16 weeks, so not very long-term. So it could be that over long-term, some patients decide to switch over to an invasive procedure. So we need more data on that. But at least these initial data that we have so far are very promising that actually invasive procedures will maybe not even be necessary anymore.
Yeah, let's turn the other side of the coin and, look at, recurring concerns with the drug itself. One of them being, the EF drops that were seen. So what are your thoughts on what we saw on the adverse effects of the drug? Were they persistent? And, how did the drug perform there?
Yeah. So absolutely, that's an important question. I think when we look at a new drug class, especially in cardiomyopathy patients who might be at risk for more complications. So overall, the collection of adverse events was very meticulously done. So essentially anything that happens to the patient while they're in the trial is being recorded in an adverse event. Most of these adverse events were thankfully not related to Mavacamten, but it was a COVID infection or a runny nose or something else. There was a small amount of serious adverse events, a total of 34 in this study. Half of them were cardiovascular, but only 2.2% overall of adverse events were deemed to be related to Mavacamten. So overall, serious adverse events were extremely rare and related to Mavacamten. Some patients had to interrupt treatment with Mavacamten because either their ejection fraction dropped too much, their QT interval increased too much, or the Mavacamten dose was over 1,000 nanogram per milliliter. So that was just sort of a cutoff range that we decided to use. Out of these 26 patients who had to interrupt Mavacamten, 20 could restart it after these markers have normalized and then were fine throughout the rest of the study so far. Permanent discontinuation was very rare, was done in 10 patients, and oftentimes due to serious complications during the trial.
Mm-hmm. And so one of the things that came up was the dose of the medication itself. So can you take us through how the medication was titrated and the intervals that were used for titration itself?
Yeah, that's an important question. We're all going to have to learn this, how to use this new medication. So after EXPLORER, everybody was taking off the medication and we started from zero. So the starting dose was 5 milligrams. And then every 4 weeks, we reassessed left ventricular ejection fraction and gradients, made sure that the gradient has decreased and the ejection fraction was still normal. If the ejection fraction was still normal, but the gradient was still high and the patient was still symptomatic, we were able to increase it, double the dose to 10 milligrams. Then there was another option to go to 15 milligrams, sort of in 4-week intervals. However, in this long-term extension so far, 85% of patients only needed the 5 or 10 milligram dose and did not go to the max dose of 15 milligrams.
Okay. And I do understand that this is an interim analysis study. Where do you think the study, I know it's hard, but where do you think the study is going in the future? And, when we do complete the study itself, what are the new things you think we'll learn from this patient population we are exploring?
Yeah, that's to be determined. Overall, we're going to follow these patients for 5 years. Right now, we only followed them as median duration for 2 months, right? The patient duration of follow-up was up to 123 weeks, but most patients were not followed that long yet. So I think it remains to be seen. I'm hopeful that we learn a little bit more about the long-term safety, about how to deal with dose titrations, how to deal maybe with background therapy. Will patients remain on their beta blocker plus Mavacamten, or will some patients actually feel so good on Mavacamten that they can decrease the beta blocker dose or maybe even come off beta blocker dose in order to feel even better, maybe more energetic. So we will see. I think there will be important future interim analysis coming out.
For sure. And speaking of concurrent drugs that these patients were on, I think one thing that is interesting is all patients were not on beta blockers, calcium channel blockers, and diisopyridamole, correct? So can you tell us more about that?
Yeah, so beta blockers and calcium channel blockers. Now, in this study, there was no disopyramide. There is other studies with myosin inhibitors that also allow concomitant disopyramide use. So we'll get more information on that. But here, background therapy was either beta blocker or calcium channel blocker. They were not allowed to be on both.
Okay, perfect.
Yeah,
So,
yeah.
I think otherwise, I think the biggest take home, what's the biggest clinical implication if you had, one big take home point you'd want all the trainees to go home with from this, very landmark study? What would you think it will be?
Yeah, I mean, I think ACC 22 was a really good meeting for Mavacamten, but more importantly, it was a really good meeting for hypertrophic cardiomyopathy. I mean, just the fact that we have a new drug class now, I think raises an incredible amount of awareness of this disorder. So patients hopefully will feel more comfortable dealing with this and learning more about hypertrophic cardiomyopathy, working with HCM centers together to treat these patients more adequately. So I think that's the biggest benefit from all this today. And hopefully in the future, we will probably find out at the end of this month whether or not Mavacamten will be used and available to us, including the fellows.
Yeah, and exciting times ahead, and can't wait for what the future holds.